senior persons from the API are with us. Our patron, Dr. K. Parik sir, our president, Dr. Grish Mathur sir, Dean ICP, Dr. Jyotirmay Paul, speakers like Dr. D C Sharma, Dr. Sanjay Badada, and Dr. Saumitra Ghosh, and Dr. VK Goel, and so many other audience. And before we start further today's proceedings, we have two very bad news. One is Dr. Sanjeev Maheshwari, our senior, our old colleague, dear colleague, and secretary for API Rajasthan for so many years, and is working for API for last so many years, lost his father this early morning. And another is Dr. Admira from the Bhilwara, lost his wife and brother-in-law in an accident last week. So first we will keep a silence for 2 minutes for the noble souls who left us for their eternal silence.
Shanti, Shanti, Shanti.
So we move towards the proceeding of our certificate course. And before that, I will request Dr. K.K. Parik sir, our patron, to say a few words. This is all because of his inspiration and moral boosting that we run CMEs and case presentation regularly at the forum of the Rajasthan API, as well as ICP, as well as the Rajasthan RSRDI. Dr. K.K. Parik sir.
Thank you, Dept. Thank you, Dr. Prakash, for your kind words. It's my great pleasure to welcome all of you, all the delegates who are attending today's certificate course program, and especially our dynamic president, Dr. Grish Mathur, under whose visionary leadership this program is being conducted, Dr. Jyotirmay Paul, very energetic and motivating Dean of Indian College of Physicians, Dr. Prakash Keswani, the coordinator of this program, whose untiring efforts for conducting these programs. He is really a person who is conducting all these programs under the auspices of ICP and API. Our today's very learned speakers, Dr. Sanjay Badada, Professor and Head of the Department, PGI Chandigarh, Dr. Saumitra Ghosh, Professor, Medical College, Kolkata, and Dr. D C Sharma, Professor, past professor and a senior endocrinologist, Udaipur. So friends, today we have got a very important topics related with obesity, and these three masters of their subject, great speakers, will enlighten us, all of us, and we hope that all of us who are attending today's certificate course program will be benefited to a great extent. So thank you so much for giving me the opportunity to connect with all of you. Thank you, Dr. Prakash, and thank you all.
Thank you, sir. Thank you for your kind words. Now I will request our dynamic leader, Dr. Grish Mathur sir, the chairman, president of the API National, and moral booster and inspiration for behind all these CMEs and regularly pushing us for all these works. I will request Dr. Grish Mathur sir to say a few words to all of us.
Thank you, Prakash ji. I extend a warm welcome on behalf of API on this fifth session of a certificate course on obesity. Dr. K.K. Parik sir, our mentor, Dr. Prakash Keswani, the man behind this program, and the esteemed faculty, Dr. Sanjay Badada from PGI Chandigarh, my friend Dr. Saumitra Ghosh from Medical College Kolkata, and Dr. D C Sharma, a renowned endocrinologist. It gives me added pleasure that two of the esteemed faculties, Dr. Sanjay Badada and Dr. D C Sharma, are from my alma mater, RNT Medical College, Udaipur. This certificate course is being appreciated widely and is getting excellent feedback. And I congratulate Dr. Prakash Keswani for all his sincere efforts and hard work in conceptualizing this ICP certificate course. Today, we are going to have a very enlightened discussion about very important subjects today: bone and joint health in obesity, reproductive health in obesity, and a cardiovascular disease in obesity. I hope every delegate will be benefited greatly. My best wishes for the success of the program. Thank you, Prakash ji.
Thank you, sir. Thank you for your kind words. We have today Dr. Jyotirmay Pal, Dean of ICP, along with us. He is again a very dynamic young man and has created so many new things in last only in few months of after taking his charge, starting newsletter, starting website, and so many courses. And he's a very brilliant and hardworking leader of ours. I will request Dr. Jyotirmay Pal, Dean ICP, to say a few words for all of us.
Thank you, Dr. Prakash Keswani ji, for your kind words. But whatever I have done, this is by active cooperation, suggestion, and support from our beloved President, Dr. Girish Mathur, and from our mentor, Dr. K.K. Parekh, also from support from Dr. Munjal, Dr. B.B. Thakur, and everybody. And because of you, such good academic program under banner of ICP is going on. Dr. Keswani ji, I must say that I have observed widely acceptance and appreciation of your particular obesity course. Even people from Mizoram, Manipur, from the farthest part of the country, they called me and expressed their willingness. And even I got many phone calls that after that whether this course will be repeated. So I wish all success of your program. And also I am thinking, even after your course module will be finished, how the other peoples can access to this program. I already started talking with the IT people, and I hope we'll do something so that this entire module will remain in an asset in our website. Thank you.
Thank you, sir. Thank you for your kind words. And we will try that these all lectures will be put in the YouTube or so. And if we can plan for printing also this handbook for this obesity by these speakers. Thank you, sir. Before going for the lectures, at the outset, I shall like to thank all the three speakers. Today we have three brilliant speakers with us, and they are very renowned faculties and very busy personalities also. In spite of that, they have given their consent and they have spared time. First, we will be starting with the Dr. Sanjay Badada. We all know that he has got such a fame in this young age in the field of calcium and bone metabolism, not across the country, but out of the country also, in the different countries also. And he's a head of the Endocrinology PGI Chandigarh, and he's none other than Dr. Sanjay Badada, and he will be giving a talk on bone and joint health in obesities. Motility is again an important part of our body, and that is many times affected in obesity. And Dr. Sanjay Badada will be enlightening us about the bone and joint health in the obesity. Dr. Sanjay Badada, you start please your deliberation.
Thank you, Prakash sir, for your kind introduction. And at the outset, I would like to thank K.K. Parekh sir, Dr. Girish Mathur sir, and my teacher, Dr. D C Sharma, sir. Indeed, he is the force because I became an endocrinologist. Otherwise, because when I was a second year MD resident at Udaipur Medical College, and he came after finishing his DM in endocrinology from All India Institute. And when I was in the unit 2 with Dr. HNS Bhatnagar, sir, he joined the institute at that time, and that was a inspiration to join the endocrinology. So thank you, DC Sharma, sir. And my job is in next 15 or 20 minutes to talk about the bone and joint health in obesity. So we know that obesity is mother of the all metabolic disorders. And many times I say that obesity is the mother and the insulin resistance is the father, and the both actually responsible for all the other their kids, whether it's a diabetes, whether it is hypertension, whether it is dyslipidemia, and now the list added is the bone health or the joint health into this also. So we know that obesity is growing the more for diabetes because increasing age, and increasing age is associated with the increase in the disease and weight gain that will ultimately predispose the osteoporosis and makes them more fragile bone structures. And that's why the obesity, when combined with the type 2 diabetes, it is not actually one plus one is 11, and increases in the those are obesity as well as
Sir, I think I have to restart. Again, start sharing the screen.
I think connectivity has become an issue.
Yes, sir.
Can you
it's
hear me
okay.
now? Yeah. So the obesity is actually defined on the basis of the BMI. So WHO defines the obesity underweight less than 18.5 kilogram per meter square. Normal weight is 18.5 to 24.9. The overweight is 25 to 29.9, and the class 1, class 2, and class 3 obesity is increasing BMI by every 5 kilogram per meter square. But there is some changes for the obesity criteria of the Indians. The reason is that probably Indians are having more metabolically active fat, and that's why the criteria is modified for us. The underweight criteria are same, but the normal weight criteria BMI reduced from 25 to actually 23 kilogram per meter square. Similarly, overweight is 23 to 25 kilogram per meter square, where what is in the WHO criteria up to the 30 kilogram per meter square. So you can say from class 1, class 2, and class 3 obesity, it was further reduced to 5 kilogram per meter square BMI as compared to the WHO standard. So there is a difference in the obesity and overweight criteria of WHO versus Indian for the Indians. So now coming to the obesity and the bone, we know the bone has three components. Two components, one is the cellular component, another is the matrix component. The cellular component is osteoblast, osteoclast in the osteocyte, and the bone lining cell. While the matrix is consist of two parts, one is inorganic component and another is the organic component. The inorganic component constitutes of the calcium, phosphate, magnesium, and another few more minerals, while the organic components are the type 1 collagen and non-collagenous proteins like osteocalcin, osteopentin, etc. So bone mass or the bone actually depends on the many factors. The most important two factors are, one is the achievement of the peak bone mass, and which is usually achieved by the age of the 30 years, And to achieve the peak bone mass, three important factors are there. One is the nutrition, especially the nutrition related to the calcium and vitamin D as well as the protein. And the second depends on the exercise or the physical activity. And third is the genetics. So these are three important factors. Those determines the peak bone mass. The peak bone mass is important. If the peak bone mass is good, the fall in the or the decline in the bone mineral density will take more time. It is very simple to understand. If suppose you have in your bank more money, then you are going to get a more interest, and it will take more time to what you call spend the money. While in case of similarity in the peak bone mass, if they're having the better peak bone mass, the bone mineral density fall will be slow and it will persist for a longer period of time, better bone mineral density. That's why the peak bone mass is very, very important. The obesity can actually interfere in the peak bone mass also if it is too much. Now coming to the determinants of the fracture risk. So we know there's two important determinants are there for the bone strength. One is the bone quality, another is the bone quantity. The bone quantity mainly depends on the calcium and vitamin D nutrition, while the quality mainly depends on their microarchitecture, the microstructure. It is maybe too, I don't want to go in too depth of the bone quality, but I'll speak briefly on the bone quantity. So bone quantity plays a major role in the bone health, and we can assess the bone health by bone mineral density by various techniques. One is, we all know that gold standard is the dual energy X-ray absorptiometry. And then next one is the another software there in DEXA that will tell you of the trabecular bone score. And the trabecular bone score is nothing but it gives a kind of microstructure information, while the DEXA does not give the microstructure information. Then you can do the ultrasound, though it is not very preferred. Then high resolution peripheral QCT, the bone biopsy and bone histomorphometry. So these are the some of the methods by which we can assess the bone health in general as well as in individuals with the obesity. So here is the DEXA scanner, and that gives you information of the bone mineral density at the spine, at the hip, and that will determine on the basis of T-score. If the T-score is less than -2.5, we call patient is having osteoporosis. If it is between -1 to -2.5, we call it is osteopenia. Or if it is -1 or less, then we call it is a normal bone mineral density. The next one is the high resolution peripheral QCT. That is a research tool, and that can be also used to assess the bone health and the bone strength. And how high resolution peripheral QCT gives a information like that up to 16 micron thickness. It is nearly a bone biopsy kind of information is provided by the high resolution peripheral QCT. Again, it gives the information on the density as well as the microstructure in these various parameters. Then on the DEXA scan, we can ask to assess the bone health by the trabecular bone score. So the trabecular bone score is done at the site of the spine only, and the normal trabecular bone score is varies at the L1 to L4 is somewhere 1.4, and if it is less than then it is determined in various form low and the very low trabecular bone score. So the trabecular bone score, as I mentioned, gives you information of the microarchitecture of the spine. Though currently the treatment is not planned on the basis of the trabecular bone score, treatment is mainly planned on the basis of the T-score only, not on the basis of the TBS. And this is the picture where you can do the bone biopsy, and that is really very, very informative, but it is difficult to collect the bone biopsy. So it is a more or less a research tool which can be used to assess the bone health at the cortical bone as well as the trabecular bone. In this particular picture, what I am trying to show you here is that the fluorescent AGE cross-link density. So you can see here that in a patient of normal glucose tolerance, this yellow or the red color is very less as compared to in the patient with type 2 diabetes. So in case of type 2 diabetes, there is advanced glycation end product is deposited, and that makes the bone more brittle because reduces the what you call bone remodeling is reduced by the advanced glycogen deposition. Then another technique is the FRAX tool, where if the facility where the bone density or the DEXA scanner is not available, we can use a calculator that is called FRAX, and you can calculate the bone strength or the prediction of the fracture risk. Here is the questionnaire where these 12 questions are there. You have to tick accordingly, but this is applicable after the 40 years of the age only. And if that will give you information about the major osteoporotic fracture, address the hip risk of the hip fracture for the next 10 years. So coming to the obesity effect on the bone health, so it is debated and partially controversial also, but that is obesity plays few roles, like it decreases the osteocyte apoptosis, it reduces the sclerostin secretion, it causes action of osteoclast is repressed, osteoblastic differentiation is increased. So this is it happens because of mechanical loading. And this is, you can say that something like a exercise. When a obese person walks, actually causes following changes in the bone, and that is responsible for the increase in the bone mineral density because of the mechanical loading. And it was a hypothesis long back. So this, according to this mechanical loading hypothesis, there is a positive effect of on the bone mineral density because of the obesity. But this effect is, subsequent studies have shown that this effect is because of the lean body mass, not because of the fat mass. So if the fat mass is more and the lean body mass is less, then we call it as a sarcopenic obesity. And the sarcopenic obesity is having the negative impact on the bone, and that predisposes an individuals for the obesity. So the obese individual, the obesity paradox is that obese individuals having high bone mineral density, and there is high risk of the fragility fractures. High BMD, but high risk of fragility fractures. This is the paradox. And why it is? Because the fracture susceptibility is reduced because of adiposity, leading to increase, leading on to the increased fragility and high risk of falling. That's why this, in spite of the higher BMD, there is increased risk of the fragility fracture is there. So in this particular cartoon, what are the various cytokines? And we know that obesity is a state of the inflammation or the continuous inflammatory states like type 2 diabetes. So in case of obesity, whether it is a central obesity or whether it is a generalized obesity, both type of obesity is associated with hypertension, dyslipidemia, and dysglycemia. And in previous slide, I mentioned about the diabetes and the dysglycemia and the bone health. In addition to this, increased levels of various adipocytokines, that is leptin, adiponectin, resistin, bisphatin, and then there is a benefit on the mechanical loading benefits are there because of the obesity. But we know all that obesity is a state of vitamin D deficiency, because when a obese person takes the vitamin D, it goes and is stored in the adipose tissue, and which is actually not regularly available in the circulation for the bone mineralization. So it is a state of vitamin D deficiency. In obesity, like subcutaneous fat or the visceral fat, there is increase in the marrow adipose tissue. And we know that osteoblast comes from the bone marrow only. So that lineage goes towards the fat adipocyte formation instead of going towards the osteoblast cell formation. And that's why the increased marrow fat can be a harmful effect on the overall bone health. And visceral fat increase, and this visceral fat increase is associated with these various cytokines, that TNF alpha, interleukin 1, interleukin 6, all these are increased. And that ultimately leads to the two effects. One is the alteration in the bone health because of this various mechanism, and because of obesity, it can also affect the joints also. And the joint affected is mainly because of initially because of a mechanical loading on the joints, because of they have to bear more weight or they carry more weight actually. And that will lead to the in form of the osteoarthritis. Now in this picture, I am showing that obesity is may be causing mainly the knee joint, but in subsequent slides, I'll show that not only the knee osteoarthritis, but osteoarthritis can be increased on various other sites as well. So the effect of obesity on the bone is there is positive effect, like to summarize, the increased mechanical load. Obese people are having more estrogen levels, so we know the estrogen is good for the bone health, and increased leptin. So you see leptin here is also there. Leptin on the negative effect is also there. So currently the situation is not very clear that leptin is good for the bone or bad for the bones. It is not very clear. But the certain other adipocytokines are known to cause increased fracture risk, like low adiponectin level, elevated TNF alpha, interleukin 6, elevated PTH, and all these actually affect. Similarly, the dyslipidemia can also affect and cause the increased fracture risk. Now coming to the term called sarcopenic obesity, the obesity is associated with low lean bone mass. So the loss of muscle mass due to obesity is called sarcopenic obesity. And this osteosarcopenia means, meaning by that less muscle mass that is having effect on the bone, that is called osteosarcopenia. So the combination of osteoporosis, osteopenia, and sarcopenia is called osteosarcopenia. Adults with sarcopenic obesity has more incidence of non-vertebral fracture than adults with obesity. Obesity and also sarcopenia alone. So basically, if the sarcopenia with obesity is there, that is much more detrimental than the either sarcopenia or obesity. So earlier I also shown that the obesity can affect the bone quantity, bone quality, and ultimately bone strength, and predispose for the bone fractures. Here already I discussed this. Old concept was there. The obesity is protective, but the new concept is coming because obesity is always most of the time associated with sarcopenia, as well as there is increase in the what you call marrow fat, and this marrow fat is responsible for the basically the MSC is going towards the adipocyte rather than going towards the osteoblast side. And that's why this old concept was that obesity is good for the osteoporosis, but the new concept is that obesity is not good for the not good for the bones. This is there. So various negative influence of obesity in the bone health is because of increased adipocytokines already mentioned, then bone marrow fat deposition, then various inflammatory cytokines. These are the three mechanisms responsible for the negative influence of obesity on the bone health. And in addition to already mentioned, the low serum vitamin D level is there in the obese individuals, as well as increased intramuscular fat that leads to poor muscle function and increased fracture risk in the individuals with the sarcopenic obesity. Few words about the obesity and the diabetes, because it is really difficult to differentiate both these two things, because significant person of obesity are having diabetes, or similarly significant number of diabetes patients are having the obesity. So it is really difficult to dissect out both the obesity and the diabetes. So we have to discuss with them together. And we all know that in diabetes is associated with increased risk of fragility fracture. Type 2 diabetes, there is almost 1.3 to 2 times increased risk of hip fracture, and approximately 1.5 times increased risk of other fractures. And in case of type 2 diabetes, there is decreased bone quality and increased fragility fractures. On the top of that, there's the various drugs, those are used for the treatment of diabetes, can also impair the bone health. And the two notable drugs, one is the glitazones, and very well documented that glitazones can harm the bone health. So the individuals, those are suffering from diabetes and having associated osteoporosis, or especially the postmenopausal women, we should avoid using glitazones, because that can further impair the bone health in individuals with the, especially the female individuals with the diabetes. So in this particular cartoon, just to make you understand that how diabetes or the hyperglycemia harms the bone. So you can see on the left panel, there is healthy bone. On the right side, there is type 2 diabetic bone. And this cartoon is very nicely showing the effect on the cellular component, like osteoblasts are reduced as compared to healthy side. osteocyte number is reduced compared to the healthy side. The adipocyte number is increased compared to the healthy side in the type 2 diabetes. And the cortical porosity is also increased as compared to the normal, as well as advanced glycation end product is deposited. Those actually impairs the bone remodeling. And on the top of that, the blood vessels. You can see here in this that the blood vessels, the more number of RBCs are there in the healthy bone as compared to less number of RBCs are there in the bone with type 2 diabetes. So basically that impairs the circulation. That may be having a direct impact that why the individuals with type 2 diabetes are having the poor outcome after the fracture or the after the hip replacement as compared to the normal individual. And it is just recapitulating this advanced glycation end product by multiple mechanisms can increase the bone fragility. And already I mentioned all these parameters that hyperglycemia, lipid accumulation, the bone marrow, advanced glycation end product that actually affect the non-enzymatic collagen cross-linking that can affect the bone. Again, diabetes is also associated with various cytokines that will further be source for the fragility fractures. And so prevention and treatment of fracture in obesity and type 2 diabetes is that early to screen, early to intervene, and as long as possible, we should use the non-pharmacological measures, especially the diet, calcium, vitamin D nutrition, as well as the exercise. Treatment options for the osteoporosis with obesity. I think there is not much difference. The treatment, there is no separate guidelines that how to treat a obese person with osteoporosis versus osteoporosis without obesity. These are the standard drugs. Those are used in the same manner. That is the bisphosphonate, denosumab, teriparatide, and the romosozumab. So now coming to the obesity and joint, and we all know that obesity is associated with the osteoarthritis of the knee, but the various other joints are also affected, like slipped capital femoral epiphysis and the femoral neck. Then at the knee joint, they can have various deformity in form of genu valgum, and that gait abnormalities are there because of this joint involvement. And the slipped capital femoral epiphysis is one of the most common association is, as I mentioned, the 80% of children, those are having SCFE are actually obese. So that is direct relation is there. And these are some of the deformities in form of genu varum or genu valgum are there. And here you can see that can be treated with the help of pin or because with the help of various other non-pharmacological measures. Osteoarthritis, it is very clear that when obese person does, there is reduced activity further increase the weight because of the reduced activity, and so there is a vicious cycle go on. Obesity, increase osteoarthritis, reduce pain, and that will go on. So osteoarthritis predisposes for the obesity, predisposes osteoarthritis, and osteoarthritis for the obesity. So I end my presentation by saying here that obesity impairs the bone and joint health by multiple mechanisms. There is mechanical reasons, there is cytokine reasons, and the exact mechanism in some of the places not that understood. But obesity and diabetes we cannot separate, and the diabetes associated increased fracture risk and the associated the poor outcome with this complication, and the obesity obviously associated increased for the osteoarthritis. Thank you very much, sir, for this opportunity. If there are any question or comment, I'll be happy to answer.
Thank you, Dr. Sanjay Badada. Thank you. It was really a very informative talk, and we have a misconception that only lean persons are prone for osteoporosis. Obese persons have much better bone health, and you have cleared that obese are more prone for the fractures, and they have to manage their weight and bone health right from the beginning, so they can prevent the fracture risk also. Thank you, Dr. Sanjay. And now we move towards our second talk. That is again an important talk.
Can I ask a question, sir?
Excuse me. Do you
Can
want
I
to
ask a question here?
Sure. Otherwise, in the end also, but if there's one question, you can ask.
So,
Yes, please.
Dr. Sanjay Badada said that there is a negative correlation of adiponectin with the bone mass. Is it so, sir? In your
I
slide.
mentioned, low adiponectin. Actually, that was arrow was low in that one. So low adiponectin, this is the poor bone health. So on that slide, there is an arrow was there going down, low adiponectin.
Right, sir. Right, sir. Thank
Low adiponectin. So our second talk is on the again on very important aspect, obesity and relation with the cardiovascular diseases. And again, we have very renowned speaker for it at this talk. He is Dr. Saumitra Ghosh. He is the professor
Can
in
I have 1 second? Hello?
Medical College, Kolkata. Dr. Ghosh, you start please your deliberation.
Can I have 1 second?
Now, is it visible?
Yes, yes, visible and audible.
Am I visible? Yeah.
Yes, yes.
Yeah, I always enjoyed listening Dr. Sanjay Badada's lecture, being his classmate. I'm listening from Mizoram.
Thank
Hello?
you, Rin. Great.
Yes, yes.
Nice to see you.
Yes, nice to see your face. Nice to see you. I will meet again. Yeah,
Thank you.
I really enjoyed your lecture. Thank you
Thank
so
you very
much.
Thank you.
Thank you. Now we can start the talk with the Dr. Saumitra Ghosh.
So thank you, Dr. Keswani, for this initiative. This is a great initiative, which is a nationwide and a international importance. So I must thank the Indian College of Physicians as well. So can everybody be
All others,
requested to mute?
except the speaker, all others, please mute yourself.
Please mute. Thank you. So I must thank this Indian College of Physicians also, because this platform has been used for this certificate course. So it is a very important topic because this obesity and the cardiovascular disease, they're interlinked and they are complementary to each other, because other than this COVID pandemic, what we see in the last few decades is the parallel two epidemics of obesity as well as these cardiovascular diseases, which are actually the bosom friends in the life and death. Because if we take this data, that since 1980s, this worldwide obesity has tripled almost 3 times in the last maybe 30 years or 40 years. In 2020 only, 39% of the adults are overweight and the 13% of the global population are obese now. It is the largest number single disease in the world today. More than 650 million adults, more than 340 million children and adolescents of 5 to 19 years, and more than 39 million children below 5 years, either overweight or obese today. And of these, cardiovascular disease is a very important killer because 17.8 million deaths worldwide are because of this cardiovascular disease. 330 million years of life is lost, 35.9 million years of disability, and 4 million deaths are directly contributed by these obesity-related diseases. And 80% world cardiovascular deaths occur in the low and the middle income countries like in India, where communicable disease is still prevalent as a cause of death, is very high. In 08, Hart's textbook of this Hart, 12th edition, chapter 91, expressed the real concern that the worldwide rise in prevalence of obesity is threatening to undo the recent advances in the prevention and treatment of the atherosclerotic cardiovascular diseases. This is such an important statement that all our recent advances in the treatment and the prevention of these cardiovascular diseases may just rewind because of this single problem, global entity, that is obesity. And if we take this death pattern or this top 10 causes of death, you will see this ischemic heart disease, stroke or other cerebrovascular diseases, diabetes mellitus, and hypertensive heart diseases, which are strongly and closely related with this obesity. They are on the topper at the killer disease. And it is a well-known fact since this Hippocrates days, when Hippocrates described sudden death is more common in those with the naturally fat than in the lean men. And in 17th century in UK, this autopsy surgeon, William Harvey, actually he was a physician, he noticed that the heart of these obese persons was large, thick, fibrous, and considerably quantity of this adhering fat over the circumference and the septum, means this interseptum and the periepicardial. Shortly before death, they observed that he suffered from the difficult breathing and orthopnea, means heart failure. So in this talk today, this outline of the presentation will be obesity and the cardiovascular diseases, the link, the outline, the pathophysiology of the cardiovascular diseases in obesity, the challenges in evaluation of these cardiovascular diseases in obesity, impact of obesity treatment on these cardiovascular diseases, and obesity paradox, which created some confusion in the recent decade, and these benefits of weight loss on the cardiovascular system of the cardiovascular diseases, and the conclusion. So to begin with, the obesity is the greatest cardiovascular risk of all things we know. It is the mother of all other cardiovascular risk factors. So it is actually a summation factor. It should never be viewed as a single entity, because what we see as a single entity are actually a multiplex of severe risk factors like diabetes, hypertension, dyslipidemia, fatty liver, increased coagulability, increased chances of inflammation, obstructive sleep apnea. Together we see in a single entity. So it is a multiplex of disease risk factor in the single disease pattern, that is obesity. So what is the pathophysiology of the cardiovascular diseases? It's a multi-dimensional thing. It is not a single thing, because if we just discuss the spectrum of this cardiovascular diseases and obesity, we'll see increased atherosclerotic cardiovascular diseases, obesity cardiomyopathy is a new term, obesity and the heart failure, obesity and arrhythmia, obesity and stroke, obesity and venous diseases, obesity and the pulmonary arterial hypertension, all are separate entities together. So atherosclerotic cardiovascular disease and obesity is a state of accelerated aging, because that leads to atherosclerotic prematurely and leads to premature death by traditional cardiovascular risk factors, non-traditional cardiovascular risk factors, and independent of these risk factors. So if we just look into these traditional risk factors, the insulin resistance, diabetes, hypertension, dyslipidemia, smoking, family history of cardiovascular diseases, advanced age, postmenopausal women, physical inactivity, atherogenic diet, etc. Other than these traditional things, non-traditional, like all these pro-inflammatory cytokines, TNF-alpha, interleukin-1, registrin, retinal binding protein, HSCRP, this VCAM, adiponectin, myeloproteinase 9, oxidative stress, etc., pro-thrombotic conditions like increased chances of platelet aggregation, fibrinogen, PI1, and these TPA, and the newer factors like lipoprotein 1, homocysteine, this impaired fasting glucose, subclinical atherogenosis, alterations in the gut microbiota, which is a big change, and it's a known fact in the last only few years. And all these major factors of increased cardiovascular diseases, increased traditional and non-traditional risk factors are hypertension, insulin resistance, dyslipidemia. Other than these diabetes mellitus, chronic inflammation, physical inactivity, these are very important other factors, which is very important. So multiple mechanisms of these cardiovascular diseases are there in obesity, like the visceral and the ectopic fat, this inflammation mediated by the cytokines and mediated by the gut microbiota, this oxidative stress, procoagulation, this accelerated atherosclerosis, endothelial dysfunction, obesity cardiomyopathy, obstructive sleep apnea, and the sudden cardiac death. These are all well-known facts. Some of them are recently very well-known. So what are the traditional risk factors of this atherosclerotic cardiovascular disease, which are very important to obesity? This obesity and the insulin resistance, this role of diabetes, hypertension, and dyslipidemia is very important. Greater risk of insulin resistance with ectopic and the visceral fat, because with this abdominal obesity, this hypertriglyceridemia, low HDL cholesterol, this high adiponectin B, small dense LDL cholesterol, inflammation, insulin resistance, hyperinsulinemia, glucose intolerance, and fibrinolysis, endothelial dysfunction, all can occur. So obesity is not all about this BMI. This concept has changed because fat mass and the fat location on adipocyte size all matters, which is not picked up by this BMI alone. Because just consider the sick fat or these metabolic factors related to the fat alteration or this metabolic health of these fatty tissues may relate to this diabetes, hypertension, dyslipidemia, fatty liver, increased inflammation, prothrombotic state, hypogonadism, and the PCOS, which may all lead to these cardiovascular diseases. And this fat mass mechanically can cause obstructive sleep apnea and the cardiomyopathy. Location of the fat is important. Ectopic fat in the muscles, liver, pancreas, kidney, heart, and the blood vessels can change this atherosclerotic pattern, hypertension pattern, and the metabolic diseases can lead, which leads to these cardiovascular diseases. And the morphology of this sick fat is also important. Large adipocyte is actually the sick adipocyte. This is very important that visceral and ectopic fat, this subcutaneous adipose tissue, which and in the form of hyperplasia, these are actually protective to our body, because this metabolic functions gets better and better if the subcutaneous adipose tissue is more and there is more hyperplasia. But when there is an ectopic fat accumulation, that causes all harmful cardiovascular consequences, because this increased renal sinus fat and the parenchymal fat increases hypertension. So this obesity and kidney disease has become a very important, and abdominal obesity causes a direct compression of the renal sinuses, and this parenchymal fat and in the form of ectopic fat is very important in the hypertension formation. Ectopic fat in the heart, in the periepic, cardium, and this epicardial fat, that can lead to coronary atherosclerosis as well as the diastolic dysfunction by these inflammatory cytokines as well as these mechanical effects. And our important study published in 2014, we have shown that the diastolic dysfunction significantly is higher with increased epicardial fat, and the odd ratio is significantly close to 10. So it is 10 times increased this diastolic dysfunction with this increased pericardial fat. Ectopic fat deposition within the blood vessels increase the stiffness, cause hypoxia, this inflammation, oxidative stress, and accelerated atherosclerosis in various ways. And ectopic fat in the liver, which is known as the fatty liver, all these, LDL, chylomicrons, free fatty acids are overflown with this, fat liver tissue, and final outcome will be VLDL production, hepatic glucose production, cholesterol synthesis. So fatty liver is overflown with the atherogenic lipoproteins and increased gluconeogenesis, lipid synthesis, and secretion, and major risk factor for these cardiovascular diseases. In another study, we have shown the ectopic fat in the liver in non-alcoholic fatty liver disease is a significant independent predictor of endothelial dysfunction and atherosclerotic vascular study. So obesity, adipokines, and the inflammation, these large adipocytes are the source of all inflammatory cytokines, which leads to this premature atherosclerotic disease. And we can see it's a battery of these large, cells which can produce these, many cytokines, and which actually produces this accelerated atherosclerosis. And it is all secreted from the large adipocyte, and that is why this large adipocyte is called the sick adipocyte. And these free fatty acids, TNF alpha, interleukin 6, resistin, and these adiponectin, they together produce this insulin resistance by just producing accumulation in the liver, skeletal muscles, vascular endothelium changes, and because of this diabetes mellitus, they produce serious changes in the intramuscular triglyceride level, glucotoxicity, decreased vasodilation, increased sympathetic tone, salt and water retention, and these changes in the coagulability. So finally, all these factors leading to this inflammation, procoagulation, and the hypertension together, they produce increased chances of atherothrombosis. So gut microbiota is a very important issue as picked up in the last few years, only because these gut microbiota is changed in the obese persons. They goes more in favor of the gram-negative, preponderance there in the gut microbiota, and these gram-negative organisms, they produce this outer sac is called this lipopolysaccharide. They are these endotoxin sources. So they produce this metabolic endotoxinemia, which causes widespread inflammation. And this gut microbiota in obesity causes adipose inflammation. And these are actually this outer part coating of these gram-negative organisms, which are preponderant in gut. They are endotoxins. They are actually lipopolysaccharides. They are absorbed like these lipids carried in the chylomicrons, and these chylomicrons can actually go with these, like the chylomicrons, go to almost all tissues, the muscles, adipose tissue, liver, from everywhere. And these endotoxins cause widespread inflammation, almost all tissues, and these are the sources of this inflammation. And this inflammatory pattern of these are changed in this insulin resistance and this gut microbiota alteration that produces atherosclerosis and insulin resistance. This is very important to understand. So obesity and hypertension, if you look into these, increased risk of increased ischemic heart disease and the stroke. because we see this with weight gain that actually shifts the frequency distribution of the blood pressure towards higher level. This is very important to understand that with obesity, this is how hypertension is a mechanical or a hemodynamic pattern, and the peripheral vascular resistance, which is also changed because overactivity of the sympathetic nervous system due to this insulin resistance, non-esterified fatty acids, this decreased this endothelial nitrous oxide production, endothelial dependent vasodilation, leading to inflammation, leading finally to endothelial dysfunction, this RAS activation. Because all gene expression of all components of this, I mean RAS, renin angiotensin aldosterone axis system in the adipose tissue is altered, and particularly this obstructive sleep apnea, they produce hypertension very commonly in association with other factors. Dyslipidemia is the increased risk of this ischemic heart disease in the stroke, and all this quantitative, kinetic, and qualitative alteration of this lipid production and this distribution all are changed, because we see this is a typical lipid profile pattern in an obese person. The chylomicron is increased, triglyceride is increased to the tune of 450, VLD is increased to the tune of 64, which is normally 30, HDL is decreased, which is actually 30 in most of the cases, that it should be more than 40 in males and the more than 50 in females. LDL cholesterol slightly increased, or there is may not be no change, because LDL cholesterol is sometimes a small dense particle. Because of these kinetic changes, because of these changes, the reduced catabolism of this LDL, HDL, there is increased catabolism, increased excretion, these chylomicrons changes are there. So they lead to a qualitative change, because the density of the palmitic acid, the density of these other content, phospholipids, ApoE, all are changed within this VLDL particle or LDL particle. As a result of which LDL become TG reached or triglyceride enriched, they become small and dense. Increased LDL oxidation can occur, increased palmitic acid content is there. So this number of the LDL particles per 100 milligram of these LDL that become more number of LDL particle come with this 100 milligram of this LDL. So all these small particles, they cross this endothelium very fast, very efficiently. And as a result of which, when they just cross this endothelium, they go into this deeper portion and they are oxidized, and this atherosclerotic process starts very well, and this development of the atherosclerotic part becomes very easy in an obese person. This is very important to understand, and that is why this LDL level does not always indicate the level of this risk in such patients. So what is obesity cardiomyopathy? It is the most important cause of the heart failure in obesity, because of the structural and the functional myocardial changes, independent of the type 2 diabetes mellitus, hypertension, ischemic heart disease, and obstructive sleep apnea. It is defined as a myocardial disease. Obesity is not explained by the traditional atherosclerotic cardiovascular disease, coronary artery disease, or other etiologies. It is independent risk factor for the LV dysfunction and heart failure, and risk increases by 30 to 100% in obesity. For each 1 unit increase in BMI, heart failure risk increases by 7% in women and 5% in men. Hemodynamic load, myocardial remodeling, metabolic changes because of this insulin resistant free fatty acid, adipokines, myocardial and the systemic RAS activation, systemic sympathetic nervous system activation, small vessel disease like microangiopathy, endocardial dysfunction, interaction with other comorbidities like hypertension, ischemic heart disease, obstructive sleep apnea, they produce this, obesity cardiomyopathy. Now I have come to this obstructive sleep apnea. Because of the that produces this sympathetic nervous system, surges the blood pressure, that produces arrhythmia, that produces hypoxia, that produces endothelial damage and the myocyte injury. It is a big risk factor in obese persons to develop these cardiac diseases. Obesity and the arrhythmias, chances of atrial fibrillation is more in obese patients, almost 2.5 times than these non-obese persons. And the cause of the sudden cardiac death is sometimes these arrhythmias, particularly the atrial fibrillation. And because of the various factors, aging, hypertension, ischemic heart disease, obesity, this impact on these LV factors, complex ventricular arrhythmias, changes in the QTc and the BMI, increased heart rate, and this atrial fibrillation is the result, and these can produce the sudden deaths. And mechanism of the atrial fibrillation in obesity are various. because of the sleep apnea, hypertension, diabetes, dyslipidemia. There are changes in the impaired diastolic function, inflammation, pericardial fat, and that all leads to this atrial fibrillation risk, atrial fibrillation burden, persistence, and the symptoms related to that. And obesity and the sudden cardiac death. It is well known since the time of Hippocrates, who actually described the sudden cardiac death very early in the history of medicine. And it is more than 40 times more prevalent in the obese than in the non-obese persons. And we have quite often seen these incidents that the obese person has faced the sudden cardiac death at night. So sudden cardiac death may have the replication greater incidence of arrhythmias and in obese persons. In the Framingham study, 40 times more prevalence. These mechanisms may be prolonged QT interval, this increased sympathetic activity, decreased vagal tone, non-extravascular fatty acids, myocardial hypertrophy, focal fibrosis, etc. Obesity and the stroke, 6 times more common in the obese than in the lean persons. For each 1 unit increase in the BMI, there is 4% increase in the ischemic stroke and 6% increase in the hemorrhagic stroke. Reason may be higher prevalence of hypertension, prothrombotic and the pro-inflammatory cytokines, increased, atrial fibrillation as well. This obesity and the venous disease is very common. Venous insufficiency, thromboembolism, edema of the feet. These are very commonly seen, and this may be because of the increased intravascular volume, high volume lymphatic overload, and reduced physical activity. All these lead together this venous disease. Challenges in the cardiovascular evaluation, that is very important because there are lots of difficulties and fallacies in obese person in the evaluation of this, because JBP, hepatojugular reflux, may not be seen in obese persons. Heart sounds appear distant. Difficult to assess the S2 split because pulmonary arterial hypertension is very common in these obese persons. But with each 1 unit increase in BMI, there is pulmonary artery wedge pressure increase of 0.4 millimeter of mercury, but we cannot assess it by clinical measures. This displacement of the heart is there, increased distance of the heart and the electrodes, increased cardiac workload, associated chronic lung disease with obesity causes a huge changes in the ECG findings. We often find increased heart rate because of the increased sympathetic nervous system activity, left axis deviation because of the malrotation, increased PR interval, increased QRS interval, QRS voltage, QTC. All these things may be wrongly assessed by in an obese person. There is non-specific STT abnormalities, ST depression, flattening of the TOA, particularly the inferior lateral leads, which may cause this false positive criteria for inferior wall MI. Left atrial abnormalities, all are there. In the echo findings, differentiating an epicardial adipose tissue with this pericardial effusion, which are all eccolucent, may often cause a difficulty in just assessing those things. Assessment of the coronary artery disease, imaging techniques, physicians are exposed to 7 times more radiation for performing a coronary angiography in a morbidly obese patients compared to normal, because sometimes it is very difficult to assess. And sometimes these nuclear cardiology imaging are required more and more to assess this significant coronary arterial disease. Now I'm coming to the obesity paradox. It has come in the recent, decade as a good thing, because sometimes they have claimed that this outcome, the cardiovascular disease and obesity, may become little protective, because where obese patients are found to have a favorable CV outcome compared to the non-obese persons, according to few faulty studies. And obesity paradox is described in hypertension, heart failure, coronary arteries, and the peripheral arterial diseases. Studies defined obesity based. Why it is faulty, I'm coming later, because these studies have been based on the BMI assessment of the obesity. But nowadays, obesity is not assessed by the BMI alone. It is this adiposity, or it is the body composition analysis, which is important, because lean mass is protective to our body, all the CV events, whereas the fat mass is detrimental. So BMI cannot differentiate the lean mass and the fat mass. Advanced heart failure is a catabolic state. So higher body weight may have a more metabolic reserve, because advanced heart failure patients become sarcopenic, and evidences suggest that the importance of the body composition in the CV outcome is very important. And it's a very important study which was carried out in the 10 different points, and of them India was one there. The 3 centers were there from the India, and carried out in Singapore, Netherlands, Taiwan, India, and USA. This multicentric study, association obesity with the heart failure outcome in Asian, it was seen the four different types. In the first category, when the patient was actually muscular and actually the obese thin, the abdominal obesity was not there, waist height ratio was normal, low, and the BMI was high because of the high muscularity. And the primary events were actually less, 11.5. And here you can see the person, this BMI was high and the waist height ratio was also high because of the abdominal fat. This other group, but this overall lean person, this BMI was low and the waist height ratio was low. Overall thin, the abdominal thinness is also there and person overall thin. Another category was the patient was lean but has abdominal obesity, which is commonly seen in India. But see, the primary events was 20%, 22%. So the different types of body composition, you just compare with this person with this person, naturally this person with the same BMI may cause primary event 11.5%, but this is not the fact, because the obesity paradox observed only with the obesity defined with BMI, and this is not the fact when the waist height ratio shows a worse composite outcome. So is obesity paradox real? No, it is not real, because it is because of the faulty study design. Because the proposed mechanism of the obesity paradox in the heart failure is increased fat mass worsens cardiac function and the heart failure. Increased lean mass improves the cardiorespiratory fitness. So obesity and the heart failure, focus on the obesity paradox. It was studied in 2017 in the Mayo Clinic, and it came to the conclusion that obesity paradox is not real in fact. So impact of the obesity treatment on the cardiovascular diseases. If we treat such conditions, that improves the risk factors, but the major adverse cardiac events benefit is not found in many studies. In the Chinese King study, the lifestyle intervention with the diet and exercise compared with the control results are delay in the diabetes onset by 3.96, almost 4 years, fewer cardiovascular disease events, lower incidence of the microvascular complications, fewer cardiovascular disease deaths, fewer all-cause mortality, average increase in the life expectancy by almost 1.5 years, and the BMI reduction of the 1.1. But the SOS trial showed that the bariatric surgery versus those who did not have this bariatric surgery was associated with reduced number of the CV events, 28 events compared to 49 events who did not have this surgery, and lower outcome number of the CV events compared to 199 to 234. So surgery had a beneficial effect because of this weight reduction. But in the look ahead study, it was found that the no major adverse cardiac events benefit was there with weight loss, though there was improvement in the cardiovascular risk factors. Independently, the blood pressure came down, diabetes factor came down, non-fatal acute MI, stroke, they came down, hospitalization for angina and this heart failure came down, carotid endarterectomy came down, percutaneous coronary intervention or the CABG came down, peripheral vascular disease, total mortality all came down. But in some factors, these major advanced cardiovascular, cardiac events where benefit was not seen. We'll have to look into it whether this is real or further studies will prove differently. Benefits of weight loss on the cardiovascular system, multiple benefits. That decreases the blood volume, stroke volume, cardiac output, pulmonary capillary waist pressure, left ventricular mass, diastolic dysfunction, and improves the systolic function. That decreases the resting oxygen consumption, systemic pressure, arterial resistance, filling pressure of the right and the left heart, resting heart rate, QT interval, and increases the heart rate variability. So we become heart healthy if we can lose weight. So to conclude, this obesity may reverse the progress in the medical science, and we have to be very important. This is a global concern. So obesity adversely affects the cardiovascular health in numerous ways and increases manifold the risk of the cardiovascular diseases. To improve the cardiovascular outcome in obesity, focus on the obesity weight loss and improved body composition through physical activity and the healthful diet, because only with the diet we may lose lean mass as well as the fat mass, but with physical activity we preserve the lean mass, we lose only the fat mass. Lifestyle modification improves this cardiovascular risk like hypertension, diabetes, dyslipidemia, and abdominal obesity. Some studies, not all, have shown the decreased overall the cardiovascular mortality, Bariatric surgery improved the CV outcome in the SOS study. CVOT trials with the medical anti-obesity treatment did not find a major adverse cardiac event benefits. Heart failure patients have favorable body composition, low lean mass, or the sarcopenic obesity may have more heart failure. A pathophysiology-based weight loss is expected to provide these cardiovascular benefits in every way. This is a very important statement that the current obesity and the cardiovascular disease epidemic, this parallel two epidemics, may reverse the trend of steady increase in the life expectancy, which medical science has brought in the last few decades, which we are experiencing these two epidemics in the last few decades. Everything may just come to rewinding stage if this kind of epidemic continues for several few decades in future. Thank you very much for your patient hearing, sir.
Thank you, sir. Thank you very much for a nice talk. It was really a wonderful talk.
Thank you,
These
sir.
are not my comments. You can see in the chat box a good number of comments have been given to you, starting from how obesity has increased in the last 3 decades. What are the pathophysiologies for the development of cardiovascular diseases in obesity, and how with reduction of obesity we can revert all these pathophysiologies. Really, it was a nice talk. There are some questions also, so we'll be dealing with them at the end of the session. Now we move towards our third talk, that is reproductive health in obesity. For this, again, we have a very brilliant speaker, Dr. D C Sharma. He has been the head of the Department of Endocrinology in the Government Medical College, Udaipur. At present, he owns his own hospital, Srajan Hospital in the Udaipur, which is a famous hospital. He is one of the most senior endocrinologists of the Rajasthan. And I invite Dr. D C Sharma to start his deliberation.
Thank you, Dr. Keswani. Good afternoon, everyone. At the outset, my sincere thanks to ICP for inviting me. Dr. K.K. Parikh sir, our mentor, our senior, our teacher, and he guides us in all the academic endeavors these days. Past president of API and ICP. Dr. Girish Mathur sir, my senior, my friend and brotherly relations, and president of ICP, Dr. Paul, secretary of ICP, Dr. Prakash Keswani, good friend, and the coordinator for this obesity program, and my co-speakers, Dr. Sanjay Badada. Thank you, Dr. Sanjay Badada, for the kind words. It's your hard work, perseverance, and intelligence which has taken you to this height. We are really proud of you. And Dr. Ghosh delivered wonderful talk on cardiovascular, risk and obesity. My job is to highlight the reproductive health in obesity. Dear friends, the cutoffs, the criteria to say obesity and all other things have been already been mentioned and discussed by the previous speaker. So I'll discuss specifically on the reproductive health, how it is affected by obesity. That the subheadings I would like to cover is reproductive health in women, how obesity affects reproductive health, the menarche, menstrual irregularities, how PCOS, which is so common, is affected by obesity, how fertility and pregnancy is affected, what is the cause of menopause, the obesity and menopause, and the relationship of obesity with menopause, and will throw some light on the reproductive health in men, where I'll discuss erectile dysfunction, as well as the fertility aspects in men related to obesity. So, dear friends, there is a complex relationship of sex hormone with appetite, energy regulation, obesity at various stages in one's life. It differs with gender. It's different in women and different in men. Here, I'm highlighting the relationship of sex hormones with appetite in women. Estrogen, in fact, decreases appetite and food intake by central mechanisms, and it decreases body weight and promotes gluteofemoral distribution of fat. That is, feminine fat is promoted by estrogen. Progesterone does the opposite, while the testosterone also does the opposite to estrogen. Testosterone increases appetite and food intake by central mechanisms. Promotes binge eating, induces accumulation of abdominal fat, and increases lean body mass. So in women who have more androgens, like many PCOS, like many women with the congenital adrenal hyperplasia, who have android type of obesity and more testosterone, they are overweight or they are obese, maybe because of testosterone contributing to increased appetite and increased food intake, and the android type of obesity, which predisposes them to heart disease, hypertension, diabetes, and insulin resistance. Now, talking about menstrual irregularities, the probability of menstrual irregularities is increased in persons with obesity. So here what is shown is elevated waist to ratio, BMI, and waist circumference. They're all associated with increasing probability of menstrual irregularities. So more the waist hip ratio, just to recapitulate that the normal waist hip ratio is less than 0.9 or up to 1. So more the waist hip ratio, you can see here above 0.9 and 1, there is a sharp increase in the probability of irregularity in the periods. Similarly, with the increasing BMI, the cutoffs of BMI were discussed by Dr. Badada, and with the increasing BMI and with the increasing obesity, which is grade of obesity, the probability of irregular cycles increases. Again, with the waist circumference, the cutoffs for waist circumference are different in males and females. For example, 80, 90 in Indians have been considered to be normal waist circumference. So with the increasing waist circumference, you can see the probability of irregularity of the menstrual cycles increases. Now, what causes the menstrual irregularity with the obesity? Where basically with the obesity, you have insulin resistance leading to hyperinsulinemia, and hyperinsulinemia leads to production of androgens in ovaries and adrenal glands. With the increasing production of androgens in ovaries and adrenal glands, there is a hyperandrogenemia leading to increased LA secretion from anterior pituitary, and there is a decrease in the sex hormone binding globulin in the liver. Ultimately, the free testosterone increases. There is increase in the aromatase activity in the adipocytes, increasing levels of estrogen. Testosterone gets converted into estrogen, and irregularly produced more levels of estrogen. This is what happens in most of PCO women. There is menstrual irregularity, menstrual dysregulation, and anovulation. So increased level of obesity with increased insulin resistance, with increased amount of androgens, ultimately getting converted into more estrogen hormone, and in an dysregulated manner would lead to irregular cycles and anovulatory infertility. What has been shown is slight amount of weight loss, just 5 to 10%. This is very important. That 5 to 10% of weight loss, just 5 to 10% of weight loss would lead to a lot of benefits in reproductive health. And also, Dr. Ghosh showed us, and it's a fact that only 5 to 10% weight loss can lead to significant benefit in terms of metabolic health and cardiovascular health. The look ahead trial showed that those who lost 10%, other trials also showed that there is significant, reversal to normal glucose tolerance, and the progression of diabetes could be halted. So 5 to 10% of weight loss improves ovulation frequency, restores normal menstrual cycle and fertility. It improves endocrine parameters, decreases free testosterone, LH, and insulin levels. So even if ideal body weight is not reached, it may not be possible to reach the ideal body weight. This much amount of weight loss restores normal hormone levels, leading to improvement in ovulation, menstrual cycle, and enhances fertility. Next, I would discuss briefly the polycystic ovarian disease. Dear friends, the prevalence of polycystic ovarian disease varies from 4% to 20 or 22% in different regions. In our country, some of the studies have shown that the PCOS prevalence is around 10%. So 10% is a pretty big number. 10% women having irregular periods and 10% young women having difficulty in conceiving because of PCOS. And the prevalence of PCOS also goes up with increasing BMI. This is what is shown here with the class 2 and 3 obesity. The prevalence of PCOS is going up. I already discussed that hyperandrogenemia, a defining feature of PCOS, is physiologically linked to obesity. With increasing obesity, there is a fatty liver, and with fatty liver, there is a decreased sex hormone binding globulin, and there are central mechanisms. Hypothalamic pituitary, there is increased frequency of pulsatile secretion of GnRH, increased LH and FSA ratio, with more ovarian androgens getting converted to estrogen, menstrual irregularities. In addition, hyperinsulinemia in a PCOS woman also leads to so many metabolic problems like more hypertension, more type 2 diabetes, more and early cardiovascular risk. So obesity is one of the important component of PCOS, and reduction in the obesity would lead to so many benefits. Weight management of PCOS women, just 5% of weight loss on clinical outcome has been shown to be tremendous. With 5% weight loss, 56% improvement in regular cycles has been observed. 48% improvement in spontaneous ovulation has been observed. 32% improvement in pregnancy rate. 25% improvement in live birth. 19.9% reduction in number of microfollicles, and reduction in the ovarian volume by 18%. So 5% weight loss is not a difficult target. And women who are coming to us with irregular periods, fertility problems, if they are encouraged to lose 5 to 10%, there can be spontaneous fertility and consumption rate will be increased. How the fertility is affected by obesity? Before I come to the details, let us understand that the prevalence of infertility in women with obesity is very high. And this is what is shown here. With the increasing weight from normal to overweight, class 1, 2, and 3 obesity, you can see the rate of infertility prevalence of infertility rate rises from 3.7 in the normal population to 5.1 up to 10.9% high infertility rate in women with obesity. So obesity plays a negative role in fertility. Now the spontaneous pregnancy rate also goes down with the maternal BMI, and this is what is shown here, that BMI about 29 kilogram per meter square is associated with decreased fertility. The probability of a spontaneous pregnancy decline linearly with a BMI above 29. Women with a high BMI had a 4% lower pregnancy rate per kg per meter square increase. So every increase in the BMI count would lead to decline in the fertility. At BMI of 40, the likelihood of getting pregnancy is 30%, 43% lower compared to normal weight. And the reverse has also been shown to be true, that losing weight or decreasing weight would improve fertility. Now, what is the mechanism of reduced fertility with the obesity? Just to give you an idea, there is early follicular atresia with increasing obesity, delayed meiotic maturation of the ova, increased aneuploidia, increased follicular apoptosis, and stromal. This is the changes in the oocyte. Then at the level of endometrium, there is decreased decidualization, decreased endometrial receptivity. There is increased free fatty acids, androgen, the endocrine milieu changes, hyperinsulinemia also plays a role, decreased gonadotropin, decreased growth hormone, decreased the other growth factors, all ultimately defining and leading to infertility. Obesity not only affects fertility in menstrual cycles, it also affects contraception efficacy. So talking about the reproductive health, one of the important concern is contraception, and obesity negatively affects contraception efficacy also. For example, obesity may affect the efficacy of hormonal contraceptives by altering how these drugs are absorbed, distributed, metabolized, or eliminated. Altered pharmacokinetic parameters and increased failure rates with combined OCs, the contraceptives patch, and emergency contraceptive pills suggest decreased efficacy of these methods. There is a 60% higher risk of failure in overweight or obese women as compared to normal women. And the contraceptive transdermal patch used, higher rate of failure again in obese women. With the levonorgestrel vaginal ring, which is a contraceptive ring, high rates of pregnancy at 1 year, that is suggesting high rates of failure of the vaginal ring contraceptive as compared to in normal weight women. Again, obesity increases the risk for technical failure of tubal ligation surgery as compared to normal women. The intrauterine devices may be one of the few reliable contraceptive options whose efficacy does not seem to be affected by BMI. So now in women, if they want to choose contraception, the intrauterine devices would be giving the same results as in a normal BMI person. Now regarding the emergency contraception, levonorgestrel is used as emergency contraception, and women with obesity had lower total and bioavailable hormonal levonorgestrel than women with normal BMI. So normal bioavailable, lower bioavailable levonorgestrel in women with obesity may play a role in the purported reduced efficacy and failure of emergency contraceptive use in women with obesity. Now, the weight loss has been shown to be significantly changing the scenario. There is a significant impact of weight loss on fertility. Say, for example, if you lose 10% or weight loss, then the conception rate improves by 88%. Yeah, if you lose less than 10%, the conception rate goes up by 54%. The live birth rate goes up by 71%. Spontaneous conception rate goes by 35%, and the time to conception also decreases. Slightly less benefits are seen when you lose little less than 10%, but the benefit is there. So meaningful weight loss improved pregnancy and live birth rates in a study investigating 52 patients with obesity and overweight and fertility. The aggregated data from 6 randomized control trials show that women who received a combination of reduced diet and exercise were 1.59 times more likely to get pregnancy than those who underwent standard care. So structured lifestyle change, encouraging obese and overweight women to lose weight by lifestyle would lead to significant change in the fertility, and many of these women would conceive spontaneously or with ovulation induction, and the results of the ovulation induction protocols also improve. The time will not permit me to discuss about the IVF, but the IVF results, the oocyte retrieval, the live birth rate, all have been correlated with the obesity, and the positive effect has been shown to be there with the weight loss. So based on these data, the regulatory guidelines, the regulatory guidelines from American Society for Reproductive Medicine says and recommends pre-conceptional counseling to address the reproductive and maternal fetal consequences of obesity. The American Society for Metabolic and Bariatric Surgery recommends bariatric or non-surgical weight loss to improve fertility, delay pregnancy by 12 to 18 months post-bariatric surgery. The British Fertility Society recommends weight loss of 5 to 10% to restore normal BMI and improve subsequent fertility and metabolic parameters. Regarding pregnancy, obese pregnant women carries different outcome results. The live birth rate is decreased in obese pregnant women. The chances of complications in obese women are higher at the delivery and during labor also and post labor also. The chances of eclampsia increases, the chances of maternal diabetes or GDM increases with obesity. So prevalence of pregnancy in women is very high. It is high and it is increasing, unfortunately. And before obese patient plans pregnancy, she should be encouraged to lose weight. Now, what is the relation of menopause and obesity? The prevalence of obesity is high at menopause. It's around 43%, and it goes up. There is a complex relationship of how menopause women at menopause leads to weight gain. In fact, at menopause, because of the decrease in estrogen hormone, there is an increase in the adipose tissue. I in the first slide showed that estrogen hormone leads to it protects against obesity, while androgen hormone, there is an imbalance of estrogen and androgen at menopause. So with the decrease in the estrogen level, the obesity increases and the lean mass goes down. And with the increasing obesity, with the increase in the adipose tissue, the energy requirement of a menopausal woman goes down, and for the same amount of exercise and diet, menopausal women tend to increase or tend to put on weight. The challenges that promote obesity in menopausal women and barriers to effective treatment are multifactorial. I've just enumerated one pathophysiological mechanism, but it's really difficult for a menopausal woman to lose weight. There is a 1.5 times, they are more likely to, the women with obesity, they are more likely to have late menopause. They continue to have periods, and with the increasing duration of menstruation, there are higher chance of endometrial problems, including endometrial cancer. Overweight and obesity are significantly associated with a 20% increased risk of menopause at age 52, 53, and 54, 55 years. And with the same, increased duration, there is increase of endometrial carcinoma also. Let us understand various risk factors for obesity and menopause, and let us also understand that some of these risk factors are modifiable, and we should encourage the perimenopausal women to lose weight at menopause, or to prevent weight gain at menopause. Like sedentary lifestyle should be discouraged. The physical activity, decreased physical activity, increased consumption of high calorie and processed food, low fiber Western diet, mood disorders and emotional eating. All these factors should be taken care. They are modifiable, and we can prevent weight gain at menopause. You cannot do much about increasing age, the hormonal imbalance, the decreased satiety, increased energy intake, and decreased energy expenditure, which is a sort of physiological or age-related changes at menopause. So ultimately, obesity would lead to altered fat distribution, increased fat mass associated with more inflammation, more oxidative stress, and all these, biochemical and molecular factors would promote increased risk for hypertension, diabetes, and ultimately cardiovascular risk. So menopausal women should be specially guided, and they should be encouraged not to put on weight and to lose weight once they gain weight. So this was all about some aspects of the obesity affecting reproductive health in women. Something about impact of obesity on male reproductive function and erectile function and fertility. Dear friends, it's a well-known fact that obesity negatively affects erectile function. Erectile dysfunction is a frequent complication in men with obesity. Studies show that obesity, and in particular, central obesity, is associated with atherogenic erectile dysfunction. Waist circumference has been shown to be a better predictor of erectile dysfunction than BMI. Now, what is the mechanism of erectile dysfunction? Decreased androgen efficacy, which would also alter the fertility. In fact, the mechanism is multifactorial. With the increasing obesity, there are central factors like chronic low-grade inflammation is there in obese gentlemen, increased levels of TNF alpha and other leukotrienes and cytokines, autoimmunity, insulin resistance, leptin resistance, and other neuropeptides are increased. The peripheral factors are also there: decreased testosterone level, increased estradiol, with the increasing adipose tissue, and because of the increased aromatase activity, the testosterone levels goes down and estrogen level goes up. There will decrease lady cell responsiveness. The decreased GnRH will also promote obstructive sleep apnea, which is as such is there because of obesity. So obstructive sleep apnea, again giving feedbacks to central and peripheral mechanisms. Ultimately, this leads to decreased testosterone, decreased spermatogenesis. Decreased testosterone will lead to decreased libido and decreased erectile function. And the vascular factors are also there in obese person. The inflammatory markers, they all lead to erectile function. The spermatogenesis and sperm quality is also affected. And there are several mechanisms proposed for, though controversial, but several mechanisms have been proposed to explain the defective sperms or defective spermatogenesis and the poor quality of spermatogenesis in obese women. Now, evidence varies as to whether it alters sperm function, though there are some reports, but there are contradictory reports also. Increases sperm DNA damage, obesity. Obesity decreases sperm mitochondrial activity. Obesity induces seminal oxidative stress, impairs blastocyte development, reduces pregnancy outcome in ART, increases miscarriage rate, and lactance. So obesity and spermatogenesis, a reduction in sperm count has been shown in obese people in a study of 225 male partners of pregnant women who conceived naturally. Obesity was significantly related to total sperm count. So compared with those with BMI less than 30, people with obesity had significantly lower total sperm count. So obesity affects sperm quality, sperm count, and fertility. Another study showing similar results and adversely demonstrating that BMI and waist rib ratio also negatively affect the sperm quality. So physiology of obesity induced sperm alteration. There are several mechanisms like accumulation of liposoluble endocrine disruptors, Ross mechanism, increase scrotal temperature in obese people, chronic inflammation, decrease Sertoli cell function, decrease fatty acid in the spermatozoa. They all alter the sperm quality and affect fertility. Now, not only this, obesity impacts on offspring health also. So offspring born to obese parents, they are also affected. In addition to the alteration in male fertility, obesity seems to affect offspring health. In animal studies, what has been demonstrated, the obesity and glucose intolerance would directly impact the metabolic syndrome susceptibility of the offspring. Sperm cells may carry epigenetic changes as methylation, which could be the underlying cause of alteration of the offspring health. So, dear friends, to conclude, I would say that obesity has a negative impact on various reproductive function, both in men as well as women. It affects fertility potential of both men as well as women. Obese women may have a menstrual irregularities and lower possibility to conceive even from adolescence. Obese women are likely to have longer menstrual periods, starting with the early menarche and late, menopause, affecting the endometrium and more chance of endometrial cancer. There is a reduced response to ovulation induction agent, more chances of infertility, the oocyte quality is affected, the endometrial function may be impaired. The outcome from various assisted reproductive techniques, including IUI, ICSI, and IVF, results are poorer in obese women. The role of men's obesity needs further investigation, though there is a clear-cut association of erectile function with the obesity. Lifestyle modification is recommended, but it increases natural conception only in anovulatory and fertile women. So thank you very much for your interest and time, and over to the organizer.
Thank you. Thank you, Dr. DC Sharma, for your nice talk. It was really informative talk, how obesity in females with or without PCOD can affect menstrual irregularities, can cause infertility, and again in the males also. There are so many comments, and there's one question for you by Dr. Prahlad Chawla. Why PCOS is lower than normal grade 1 obesity?
Sorry, why PCO?
PCOS is lower than normal with grade 1 obesity. I also do that. Dr. Prahlad, are you online? So possibly he was.
Yes, actually, yes, I am Dr. Prakash Chawla.
Yes. Can you
Yes, Chawla, please.
clearly ask your question?
Actually, one of your slides was showing this things. That is why I asked the questions. When you have presented this is about the PCOS, then I was saying in normal it was around 9%. In grade 1 it was 5.2%. So that is why I had these questions in my mind. I don't know if maybe the slide.
Okay, I didn't get your question, but let me clarify that PCOS, different types of PCOS. Most of PCOS are obese, but there is a lean PCOS also, and PCOS can be there with normal weight also. But one thing the message which I wanted to give was, with increasing obesity, there are higher chances of PCOS, at least PCOS morphology in sonography, and which is negatively correlated with the fertility outcome.
Thank you, Dr. DC Sharma. Another question is there by Dr. Sanjeev Kumar. in clinical practice, we have found that orlistat is not much effective for weight loss, even less effective than Herbalife product, which has huge market, but these products don't have trial and safety data. So we can't advise as a doctor. What is your opinion about this? And share your experience about the oral or injectable semaglutide.
I fully agree with you, doctor. First and foremost, lifestyle modification. Lifestyle modification and reducing energy intake, reducing calories intake, reducing the fatty food, sugar and sweets should be encouraged, and regular exercise should be encouraged. We know all this, that lifestyle modification is the cornerstone of therapy for obesity. And after that, the pharmacotherapy comes. So amongst the pharmacotherapeutical agents in our country, we have only orlistat. I fully agree with you that orlistat, at the best, the trials have shown that the orlistat reduces weight by maximum of 5%. And those who are non-compliant, they may not lose anything, even with the orlistat. There are significant side effects in as high as 25 to 30% people taking orlistat. So we are left with very limited choice as far as the pharmacotherapy is concerned. Regarding the semaglutide, to best of my knowledge, only injectable liraglutide in the doses of 3.5 milligrams has been approved for weight reduction amongst the class of GLP-1 receptor agonists. The offline use or the under the table use or the the individual experience of many people who have used semaglutide, including oral semaglutide, has been encouraging. I have not used this drug for the weight reduction.
Thank you, Dr. Sharma. There's a question for Dr. Sanjay Badada. I think he has to rush to PGI for some residence activity. Dr. Badada, are you there? Question is by Dr. Ankit Anand. Sir, any objective method of assessing sarcopenia in patients? So I will take the liberty to answer this question. Sarcopenia can be given measurements by three parameters, can be defined by three parameters. One is the muscle mass, other is the power of the muscle, other is the performance, and various groups, including European Working Group, Foundation Group by the National Health Insurance of the UK, Asian Working Group, International Working Group. These three parameters are being taken. And for muscle mass, appendicular lean mass divided by the height square, and some have also used this appendicular lean mass divided by the BMI as an index for the muscle mass. And for power hand grip, 26 kg for the men and 18 for the females. And for the performance, that includes 400-meter walking brisk in less than 6 minutes. These parameters are taken for defining sarcopenia in our clinical settings. Another question is, why is the dose of abendronic acid or what is the dose of abendronic acid or zoledronic acid? Which patients are ideal candidates, and what are the precautions to be taken while giving this drug? Dr. D C Sharma, will you like to answer this question? What is the dose of abendronic acid or zoledronic acid?
The dose of abendronic acid is 150 milligram once in a month. And like for any other oral bisphosphonate, the precaution is that the drug should be taken empty stomach in the morning, and the person should be asked not to lie down at least for 1 hour after taking this drug orally, because this would lead to esophagitis. So person should remain ambulatory or should sit or stand, should not lie down for 1 hour after taking any oral bisphosphonate. Regarding zoledronic acid, wonderful drug, once in a year, injectable drug, 4 to 5 milligram dissolved in at least 100 ml of diluent, maybe normal saline, to be given not less than over 15 minutes. So it to be infused over, say, 30 minutes or so, once in a year.
Dr. Saumitra, you have a big number of comments in the chat box, and you have done a really wonderful job by giving so many good slides, so many good things, obesity paradox and sarcopenic obesity again.
Mm-hmm.
And what
you have given the answer, very good answer.
Yes, and that was a good. These all were giving a good information about obesity and cardiovascular diseases. What will you prescribe? Advise the patients who comes to you for reducing the cardiovascular risk, reducing the muscle, reducing the weight, or increasing the muscle mass.
Both. Decreasing the fat mass and increasing the muscle mass. Decreasing the fat mass is very important by this lifestyle and this dietary and the exercises, as I mentioned. But increasing the muscle mass, as you said, the sarcopenia is a big risk for all these cardiovascular risk factors. If we can increase this muscle mass, muscles are the drivers of our body. This is like the engine of a car. So if we can increase the muscle mass, so that is the biggest thing. And but just decreasing the muscle mass as well as the fat mass by decreasing the body weight without consideration in the body composition may not bring good things.
Thank you, Dr. Saumitra Ghosh.
Yes.
And I thank you all the speakers for your wonderful job, and thanks to the audience also. Dear participants, till this time we had 11 lectures, starting from what is obesity, classification, diagnosis, association with the diabetes, cardiovascular disease, OSA, and so many things. In the next 2 sessions, we will be having 5 lectures on the management. In the next session, Dr. Sanjay Kalra from the Karnal and Dr. Shailesh Loda from Jaipur will be giving lectures on the obesity and lifestyle modification and diet. And in the last session, Dr. KVS Harikumar, Dr. Ajay Shah, and Dr. Bansali sir will be giving opinion regarding the management. So we will be completing these series of lectures in the next 2 sessions. And hopefully on the last day only, you will be getting the certificates also. Thank you very much, all the participants. In the last, I will like to thank the speakers, Dr. D C Sharma, Dr. Saumitra Ghosh, for their wonderful presentation, giving so much time. Thank you very much, sir. Thank you. Bye-bye, sir.
Gosh, and everyone, yeah.
Bye.